First, we have a talk by Dr. Subramanya, Chief Intervention Cardiologist from K.S. Hegde Medical College. He will be speaking on ECG machine, paper, standardization, and PQRS complex.
Good afternoon, everybody. First of all, I would like to thank Dr. Prabhakar and the organizing committee of this ISECON for giving me this wonderful opportunity. I would like to congratulate Dr. Prabhakar for taking such a good initiative in organizing a national level ECG conference. And I think I request all of you to make the best use of this opportunity. Today I've been given a topic of the basics of echocardiography. I'll be speaking about the ECG machine, the leads, the paper, standardization, and the PQRS complex. The first three things what we should know is the difference between the electrocardiograph, and electrocardiography. Electrocardiography is a technique where we record the electrical activity generated by the cells of the heart that reaches the body surface. The graph which is obtained is called as an electrocardiogram, and electrocardiograph is a machine that records this ECG, and it consists of a sophisticated galvanometer that detects and records the changes in the electromagnetic potential between a positive and a negative pole. So this is the electromagnetic force which travels from a positive to a negative terminal. When it goes from a positive to negative terminal, we get a positive deflection, and when it goes away from the positive terminal, we get a negative deflection. So this is how the recordings which have been done. If you see at the endocardial level, we get a tracing like this, and then epicardium level, we get an action potential like this. And the electrocardiograph, when it is recorded from on the body surface, we get a recording with a P, QRS, and T and U waves. So these changes are recorded on a graph paper as a plot. We know it, there is an x-axis and there is a y-axis. The horizontal x-axis indicates the time, and the vertical y-axis represents the voltage of the graph. So each lead provides a view of the electrical activity as seen from its particular position on the body surface. A combination of leads allows us to see the electrical activity from various viewpoints. So this is how an electrocardiographic paper looks like. As all of us have seen it, there are small squares and there are big squares. There are 5 into 5, 25 small squares constitutes a big square. Each small square, horizontally when we see, each constitutes about 1 millimeter each of this in size. 5 squares becomes 5 millimeter, and each millimeter represents a time of 0.04 seconds. So one big square or one big box represents 0.2 seconds, and in a second, 5 such big boxes will move. So the paper speed of the ECG machine is 25 millimeters per second. Coming to the vertical measurements, again if you see, each small millimeter represents 0.1 millivolts, and a big square represents 5 millimeters represents 0.5 millivolts. So with this, just how to calculate the heart rate. So there is a very simple formula. We have to calculate the distance between the RR interval. Like in this patient, if you see, the distance between 2 RR intervals is about 10 small squares. So 1500 divided by 10 is 150. So 150 is the heart rate of this patient. Now coming to the electrode placement. So there are 3 important electrodes which is connected to the right arm, left leg. To the right leg, there is another electrode which is connected for earthing purposes. So this is how it is represented. I will tell each of these things in detail. So there are 2 types of leads we know in a conventional 12-lead ECG. There are frontal planes and horizontal planes. The frontal planes has got 3 bipolar limb leads, 1, 2, 3, and unipolar 3 leads are there, which is augmented VR, augmented VL, and AVF. and there are 6 horizontal unipolar precordial leads from V1 to V6. So what is the importance of each of these leads, and what does it signify? If you take lead 1, it is connected between the right arm and the left arm. So the right arm has got a negative terminal, as you can see here, and the left arm has got a positive terminal. So when the electromagnetic force or the vector travels towards the positive electrode, so we get a positive deflection. The lead 2, the negative terminal is connected to the right arm and the positive terminal is connected to the left leg. So when the vector passes, so we get again a positive deflection when it goes towards the positive pole. In lead 3, the positive terminal is the leg and the negative terminal is the left arm. So again we get a positive deflection. So when Wilson in 1974 found that there are a lot of gaps in assessing this with this system, just connecting with these 3 leads, lead 1, 2 and 3. So he proposed 3 more leads to fill up these gaps. So these were called as the AVR or augmented V leads. So here what happens, this is again a unipolar system where there is an exploring electrode which is connected to that particular limb. Like in AVR, it is connected to the right arm. In AVL, the exploring electrode is connected to the left arm. And in AVF, it is connected to the left leg. So, and the rest of the 3 leads is connected to one single pole, which is a negative vector, which is represented by, which is called as a V lead, which indicates 0 potential. So whenever the electromagnetic force travels, so we get a deflections accordingly. So what happens in AVR, since the deflection is going from the positive pole is connected to the right arm, the deflection goes from below up, so which is going away from it, so we get a negative deflection in this, in AVR. So all the waves are inverted in this. Similarly in AVL and AVF we get a positive deflection because of the electromagnetic force going towards the positive pole. And initially when it was proposed, the leads, the graph, what they used to get was a very small graph. They could not appreciate the various waveforms. So they augmented these leads so that a better picture could be obtained. So it is called as an augmented VR, VL or VF leads. So this is the horizontal chest leads which have been connected. So there is V1 to V6. V1 is present at the level of the 4th right intercostal space. V2 is at the same level and the 4th left intercostal space. V4 is in the mid clavicular line. V3 is between V2 and V4. At V5 indicates the lead is present in the anterior axillary line, and V6 in the mid axillary line. So this is about the representation of the QRS axis by this Einthoven's triangle. It is an equilateral triangle. When all the vectors are added, we get a 0. So the normal axis in a human person is between -30 to +90 degrees. When we call it as right axis deviation, there is from +90 onwards we get a right axis deviation. If it is less left axis deviation, it is -30 onwards. Northwest axis is between 90 to 180. The details of which will be told by my next speaker. This is how this axis is being represented on the chest of a person. If you see here, this is how it is represented. So AVR is -150, AVL is -30, and AVF is +90. So now coming to the next important aspect of the ECG is the standardization. So before we start reading an ECG, we have to first see what is the standardization which has been maintained on this particular graph. So normal, it indicates about 10 millimeters, which is equivalent to 1 millivolt. The signal which will clearly indicate that whether the subsequent ECGs what we are getting is a normal ECG. Because this is, as we see here, the first A represents, this is how a normal standardization curve represents. We see here the corners of these standardization is at right angles to each other. There are 2 important things when if the stylus of the ECG recording graph machine becomes very stiff, then we get over damping. That is indicated by, if you see here, the edges of this standardization graph, it is becoming curved. So that means that it indicates an over-damping, or the stylus has become very stiff. So this, what happens, as a result of which we will not get the deflections very clearly. See, if you see the normal ECG here, because of over-damping, if you see that the QRS complex size has become lesser. Similarly, the opposite to that will be under-damping, where what happens, the stylus becomes too loose, so that there is it results in sharp spikes in the ECG graph. If you see here, this is the QRS complex, this is a normal ECG. We see that the size actually appears much bigger than the normal. So this is very important to see the standardization before we start reading the ECG. So what are the basic ECG deflections what we see? It is represented by the P, QRS, T and U waves. All of us know it. And each of these has got the significance of these various intervals. Dr. Manjunath will be speaking more in details about this. So if we see the basic deflections, the P waves indicates the atrial depolarization. So whenever the stimulus comes from the SA node and reaches the atrium, there is a formation of the P wave, which indicates the atrial depolarization. The QRS complex indicates the ventricular depolarization. The T wave indicates the ventricular repolarization. And the U wave indicates the repolarization of the Purkinje fibers. We can as well go to the details in this pictorial representation. Indicates that from the SA node, the impulse has reached here. From there, during the P wave, the impulse is getting transmitted through the AV node. Then, during the PR interval, we can see that it is going through the bundle office and then the bundle branches. And by the time it reaches the QRS complex, it has already reached the Purkinje fibers. And the ventricular depolarization has started. So when we finally describe an ECG, so what are the things we should describe in an ECG? First, we should tell about the rhythm. What is the rhythm of this patient? Is it a sinus rhythm, or the patient is in a ventricular atrial fibrillation, or any other type of arrhythmias if the patient is having, like ventricular fibrillation or whatever it is? We should first tell about the rhythm. Next, we should tell about the rate. What is the rate? Is it in the normal rate, or the patient is having tachycardia, or if the patient is having bradycardia? We should also tell about the axis. Is it a normal axis? Is it a left axis deviation, or it is a right axis deviation? Then we should comment about each of these deflections. We should comment on the P wave, the PR interval, the QRS complex, the ST segments, the T wave, U wave, and the QT interval. To tell briefly, this indicates the beginning of the P wave to the beginning of the R wave or the Q wave. It is called as the PR interval. After the end of this P wave to the beginning of this R, this will be the PR segment. Then the QRS complexes will begin, which is almost about 3 squares. Then at the point when the S waves stop and the T wave, at this junction we call it as the J point. And then we get from the end of this S wave to the beginning of this T wave forms the ST segment. Then the T waves are there. So what are the important practical points for recording the ECG? So first important thing is the electrodes. The electrodes should be selected in such a way that there should be a maximum adhesiveness. The electrode should stick to the chest of the patient very tightly. So if it is not touching properly, if it is loose, then we will not get a proper tracing. Second thing is that patient should have a minimum discomfort. Sometimes if you see, particularly this is important while doing a treadmill test. So what happens if the patient has got a hairy chest, so that hair should be removed, and because while removing the leads you may have severe pain. We should also try to have a minimum electrical noise. Like if there is a high voltage transmission close by, we may not be able to get a good tracing because of the noise. And we should also minimize the skin and electrode interference. There should be an effective contact between the electrode and the skin, which is very important. And the skin also should be clean, and we should avoid these two important things. One is what we call it as a baseline wander. That means what happens when we start taking an ECG, sometimes we see that suddenly the ECG will start going down, or the graph will start going up. So if it is going slowly, we call it as this baseline wander. So we should avoid this. And sometimes we see with every beat, we can see the ECG beats moving up and down, changing very abruptly. We call it as a shifting baseline. This becomes important in interpretation of these various complexes. Calibration is very important. Sometimes if you feel that the patient is having an LVH kind of thing where we see that QRS complexes are big, sometimes we might have to reduce this calibration as well. We should also see for this ECG paper speed, it should be at 25 millimeters per second. Sometimes if we see, we have to see the complexes very clearly, like P waves, if there is a bifid P wave or some other details if it is needed, then we can go at a faster speed. We can go at 50 millimeters per second to see these waves very clearly. And we should try to reduce the artifacts maximal by either external artifacts or internal artifacts. External artifacts could be because of sometimes the leads might be touching to a metallic frame of the cot, or patient might be wearing some ornaments like particularly like chain or some ring and all these things, some watches, or if the patient is having some mobile phones, so there could be a definite external interference. Internal interference also we should try to avoid. Like particularly if the patient is having some shivering and all, it will be, we get a lot of these artifacts. And very important to take the ECG in a supine position. Thank you.
The computer ECG reports come very often.
Yeah.
How often we find the major mistake, how often we find the minor mistake. Very often it mistakes.
That's what. See, the clinicians, the patient's condition has to be correlated with the ECG what we get. See, many of the times we see that the early repolarization changes, that particularly the ST segment elevation, it might be interpreted as an anti-wall MI. So we should be very important to correlate it clinically to come to a diagnosis. So it will fairly give us a, this one like that QT interval prolongation and all it will give us, because usually we miss this. So all these things we can see, but most of it we should base it on the clinical correlation with the patient. Yeah. Yeah. See, this is a very important, important question which all of us should know. See, the monitors what we use in this ICU and other setups, it is used only to see for the rhythm of the patient. Whether the patient is having a sinus rhythm or if the patient is having a tachycardia, bradycardia, to see the rate. And many of the times we see that, suddenly we see that the ST segment is up or ST segment is down, and this will be there. So we should not interpret more on this monitor. So to interpret an ECG, always we should take, even if the patient is connected to a monitor, we should take a fresh ECG and see, correlate with the patient's finding with that of the ECG what we get on a 12-lead ECG. So never correlate the findings what we get on the ECG monitor in this ECG. It is just to see the rhythm. If the patient's rhythm suddenly changes to atrial fibrillation, then it becomes important.
How much importance do you give to the earthing in the present ECG machine?
I didn't get your question.
Earthing.
Earthing, see, all the present day ECG monitors, if you see, we have 4 color-coded leads which are connected. So one of these leads which are connected to the right limb is an earthed limb. On that, each of these ECG leads, if you see that, even with the color coding, there is right RA, RF, LA and RF will be written. And left foot also will be written. The lead which is written with the RF is used for earthing purposes, which is very important.
But earlier this is also at the same quality, but their earthing was done in a separate way. Now it is obsolete.
No, I think it has been used in all whatever ECG machines what we use now. We use the earthing. Earthing, separate earthing. Yeah. No. Present ECG machines have got a separate limb which is connected to the right foot, which is used for earthing purposes only. Earlier it was different.
If I am correct, earlier it is also at the right foot connected. It was an indifferent lead we got.
I exactly don't know the details of this, because what we usually use is this color coding, and with the right foot we use it for earthing.
Thank you, sir. The next session is by Dr. Manjunath, Chief Intervention Cardiologist from AJ Institute of Medical Science, and he will be speaking on measuring intervals, PR, QRS, QT and importance.
Good afternoon, dear friends. At the outset, I thank Dr. Prabhakar for giving me an opportunity. I'm just talking today about the basic ECG deflections, and most of this, all of you know very well. It's a very basic, and I think we might have read in our first MBBS physiology Guyton textbook. So, the basic deflections, as you know, we already, Dr. Subramaniam has discussed. 1 minute. This is a PQRS, T and U waves, and he has already told that the P waves, QRS, the importance of PQRS, T. Now the P waves is the contour of P wave is smooth and monophasic, and except in V1. Of course, we get positive P waves in first 2 and AVF and V4 to V6, and negative P waves in AVR, which is common. And we have a P wave axis also. It varies from 0 to 75, plus 75. And the duration of P waves are usually less than 120 milliseconds. Amplitude is less than 2.5 millimeter. And it is biphasic in V1, as you know that the positive initial component and the negative initial next component, it represents left atrium as well as the right atrium simultaneously. Now coming to the PR interval, is a very important interval. When we read an ECG, we try to find out the ECG PR interval, because it is one which represents the duration of the conduction through the atria to the ventricles. So always we look for PR interval prolongation or short PR interval, which are pathological. I'm only dealing with the physiological tests. Now the PR interval actually begins at the onset of P waves, and it ends at the onset of the QRS complex, as depicted here. So the duration is normally 0.12 to 0.2 seconds. Now coming to the PR segment is very important. It's also called as PQ segment. It represents the duration of the conduction from the ATO and AV node down bundle of his and through the bundle branches to the muscles. So till that is the complete ventricular depolarization it represents. So it actually begins at the end of P wave and ends at the onset of QRS complex. So that is the PR segment.